Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about the common faint. Medicine, we call it syncopal attack. Up until 2001, this very common condition didn't even have a standard definition. But now it's defined as a transient loss of consciousness due to not enough oxygenated blood getting to the brain on a temporary basis, has to be rapid onset, short in duration, and has to be associated with spontaneous and complete recovery. Now, some people think that they haven't lost consciousness, and if you really haven't, then you have not had a syncopal attack. You've had maybe a fall or a dizziness or vertigo or a transient ischemic attack, a mini stroke, maybe a psychiatric episode or cataplexy, but you haven't suffered from syncope. You haven't fainted unless you lose consciousness, and you can't have any focal neurological signs. The condition has to come on very rapidly, less than a minute from the onset of symptoms, and it's relatively short in duration. So if it's long in duration, more than a few moments, then you haven't had a syncopal attack. You've had a coma or a stroke, or maybe you're intoxicated because of either drugs or alcohol. Maybe you had a hypoglycemic attack, but you have not had a syncopal attack unless it's very quick in onset, very quick in offset. The recovery has to be complete and spontaneous. So you don't need to be resuscitated. The average duration of a syncopal attack is only about 12 seconds, during which you're unconscious. Now, it can be somewhat more prolonged if you're not lying flat. So, for instance, if you're strapped to a wheelchair, or if you faint while you're on a commode and now you're wedged between the commode and the wall, still in a seated position, then the syncopal attack is going to last longer. But for the overwhelming majority of people with syncope, they lie flat, and when they do lie flat, then you get the perfusion to the brain again. Well, if we look at the reason people faint, sometimes it might be from head trauma or concussion. That's not from cerebral hypoperfusion. That's not because of a lack of oxygenated blood getting to the brain because of either dilation of the blood vessels or a slowing down of the heart. And it's not epilepsy, because in epilepsy, you've had an electrical discharge of the nerve cells. That's why you develop your loss of consciousness. So we've ruled all of that out. Well, syncopal attack, sometimes from the moment that you can sense that something is amiss, until you actually lose consciousness, you can have what we call a pre-syncopal attack, or the prodrome. And that's associated with some dizziness and lightheadedness and some feeling that you're about to faint, or some weakness or fatigue, or some ringing in your ears, or some graying of the vision. And syncopal attacks are very common. It's estimated that somewhere around a third to a half of people are going to have at least one syncopal attack in the course of their lifetime. Look at medical students, about 40% in a recent study. Anybody who has sufficient provocation can have a syncopal attack, but some people are just more predisposed than others. If we look overall at the different age groups that are affected, we have two peaks where they seem to be extremely common. One in those individuals between about age 10 and 30, with a peak age at about 15. Then we have another group in older individuals over age 70. So if we look at people between 60 and 70, the likelihood is about 6 per 1,000, but over age 70, it doubles to about 12 per 1,000. And if we look at the likelihood that you're going to have a second attack once you've had your first attack, it's about 60%. It's more than 80% if you've had 2 attacks, the likelihood of a third attack. If we look at the sex difference in syncope, we find that overall there's a slight predominance in women than in men, but that slight predominance occurs because of the increase in neural mediated syncope in younger individuals. So that youth age group, the 10 to 30, more women than men. If we look at the older age group, people over age 50 or 60 or 70, it seems that syncopal attacks occur equally commonly in men and women. with age, especially due to taking a variety of medicines, or maybe having other medical diseases, or abnormality of some of the reflexes inside the body. Not the reflexes that we test with the little hammer, but the reflexes in your carotid sinus, or in your aortic arch, or in the heart itself. Those reflexes age just like everything else in your body, and when they age, then they sometimes make mistakes as you change your position. Seems that there might be a family history, especially in those people who are relatively young, less than age 20 or 30. Certainly doesn't seem to be any genetic predisposition in older individuals. Most people who have a syncopal attack don't see a doctor, don't need any medical care, don't need any medical evaluation, and it doesn't change your overall life expectancy. But as the person gets older, then the likelihood of cardiovascular problems increases. So if a person happens to be 70 years old and has the first syncopal attack, then we suspect that there might be some underlying medical issue. Now, when we talk about the syncopal attacks, most of them are due to what we call neurologically mediated syncope. And this means that because there's some abnormality of some of the reflexes inside the body, that the blood vessels, when you stand up, instead of constricting, they dilate, and the heart, instead of speeding up, slows down. And when it does that, then obviously there isn't enough blood and blood pressure to keep the blood flowing to the brain, and you faint. Another condition is called orthostatic syncope. Orthostatic syncope means that there's actually some disease of those reflexes inside the body. It's not just a sporadic thing. When we talk about the orthostatic syncope, we tend to think more of institutionalized elderly individuals rather than people who are living in the community. We think people take more vasodilating medicines, medicines that make the vessels weak. Think of people who suffer some physical impairment so they're not up and about, maybe people who have a neurologic condition. And then we have cardiac syncope. Cardiac syncope, you faint because you have some arrhythmia or some structural disease of the heart. That's what everyone seems to worry about, but that really is a minority of the cause of syncopal attacks. And obviously, if your heart doesn't work right, it can't pump enough oxygenated blood, that may cause the situation. Now, most attacks occur when you're standing upright, but some of them, notoriously, if you have your blood drawn, are when you're lying down. Well, in the upright posture, when you go from sitting in a chair or lying down to standing up, the blood is going to pool in your legs and in your abdomen. And when it does that, you lose about 500 milliliters to 1,000 milliliters of circulating blood. That means the blood is down there. It's not getting back to your heart. And if it's not getting back to your heart, the ventricle doesn't have as much blood, so it doesn't pump out as much blood. If it doesn't pump out as much blood, your blood pressure is going to go down. And then theoretically, if you're otherwise normal, you're going to have some compensatory reflexes. The compensatory reflexes going to stimulate the constriction of the blood vessels and stimulate the increase in your heart rate. And that normally happens, and you don't have to think about it. But if we have a situation where when you stand up, then you don't have those reflexes, and the blood is pooling down in your lower portion of your body, then your mean arterial pressure, your systolic pressure, is going to fall. And it's going to fall to, say, less than about 60 millimeters of mercury. That's when you get your prodromal symptoms. Normally your blood pressure should be about 120/80. Well, when it gets down to less than 60, then you're at risk. And when it gets to be less than 50 at heart level, well, that means less than about 30 in your brain itself, you're going to become unconscious within about 7 seconds. Now, under normal circumstances, we have those internal reflexes that I mentioned that are in your carotid sinuses and the aortic arch and in your ventricle and some other areas inside the body. And that's going to keep the blood pressure relatively normal, keep the perfusion of your brain relatively normal. But if there's a temporary glitch, then unfortunately that's when you suffer the syncopal attack. and you suffer the syncopal attack, oftentimes within 5 to 10 seconds of whatever the event is, under normal circumstances, the cerebral blood flow is somewhere around 50 to 60 milliliters per minute per 100 grams of brain tissue. And it's relatively equal no matter what your blood pressure is. If your blood pressure is between, say, somewhere around 50 to 150 millimeters, your blood pressure from autoregulation is going to keep it normal. So under normal circumstances, 50 to 60 milliliters per 100 grams of brain tissue. You're going to have impaired consciousness when that falls to about 25 milliliters per minute per 100 grams of brain tissue. Now, if we talk about neurologically mediated syncope, it just is episodic. It's not all the time. It's typically when you're upright, but as I mentioned, if you're having your blood drawn, could be while you're lying down or sitting in a chair. And it's due to the sudden temporary change in the autonomic nervous system efficiency, where all of a sudden the blood vessels dilate when they should constrict and the heart slows when it should speed up. And you can have predominant problem with either the slowing of the heart or predominant problem with the dilation of the blood vessels, or they can be combined. So what are some of the common triggers of the common faint? Emotions or pain, fear, laughing, orthostatic stress when you stand up, maybe the sight of blood, or maybe we have your blood drawn or IV inserted, or an increase in pressure inside the chest cavity, for instance, if you're bearing down to have a bowel movement or you're coughing. And sometimes due to some stimulation of some of those reflexes inside the body that we mentioned. So you have reflexes in your pulmonary circulation. So coughing and sneezing may be associated with syncopal attacks. Young people who have asthma or people who have COPD. Some people develop syncopal attacks when they swallow periodically for whatever reason it occurs. It stimulates the vagus nerve. The vagus nerve, when it's stimulated, slows the heart rate. Rectal examination can cause it. Defecation, when you have a bowel movement, you can faint. Some people with urination can develop the same sort of a problem. Or if you have a prostate massage. Or some individuals, we find that if they're wearing a tight collar and they turn their head, well, that tight collar might constrict the area around the carotid sinus, and in that case, that might cause a person to faint. Some people faint with migraine attacks. Some people faint with increase in the ocular pressure. And some people faint because they've been exercising, and now all of a sudden, especially in the hot weather, they stop exercising. So the blood vessels are dilated because the blood has to get to those muscles that are working. But now all of a sudden when you stop exercising, the blood vessels are still dilated, but the muscles aren't returning the blood to the heart because they're not squeezing down. That can lead to some pooling. And then we have another condition, and we call it the postural orthostatic tachycardia syndrome, where you all of a sudden find that the heart rate goes very fast. It can increase, it can speed up to more than 30 beats a minute, more than normal. And then all of a sudden it slows down. And that can lead to the syncopal attacks. Same thing. If you hyperventilate, you're going to blow off all the carbon dioxide. When you blow off the carbon dioxide, the vessels in the brain constrict. That can cause a syncopal attack. So syncopal attacks, about a third of the time they occur without any of those prodromal symptoms, especially in older individuals. Now, syncopal attacks oftentimes cause those unexplained falls. But if a person has a syncopal attack and doesn't have any kind of a warning, then especially if a person's a little bit older, we worry more about a cardiac problem. But usually somewhere between 30 seconds and a minute or so before you pass out, you have that lightheadedness and the fatigue, and you start to sweat, you become pale. Some people complain that their skin feels either warm or cold, or they have clammy skin, or they can suffer from what they think are palpitations, difficulty concentrating, weakness, restlessness. Some people hyperventilate. Some people develop a certain period of nausea. And some people actually yawn. Yawning is a relatively common forerunner of syncopal attack. Well, syncopal attacks tend to occur more commonly if you're motionless and if you're in a warm ambient temperature, if you're volume depleted. So maybe you're dehydrated, it's summertime and you've been perspiring and you haven't been keeping up on your fluids, or you're taking a diuretic, or you suffer from some nausea or vomiting. Maybe you've been drinking alcohol that acts as a diuretic, or maybe you're anemic, so you really can't pass some of that oxygenated blood to the brain because there isn't enough to carry the oxygenated blood. Now, sometimes it can be a little bit difficult to differentiate syncope and an epileptic attack, because somewhere between about 10 and 50 or 60% of the time, there's some shaking movement that occurs. But the shaking movement that occurs with epilepsy occurs before a fall. With syncope, it occurs after a fall. The eyes tend to remain open in a syncopal attack. They're deviated upward, the pupils dilated. Sometimes people have a roving eye movement. Now, with an epileptic attack, you have a period of confusion afterwards. You don't with a syncopal attack. Now, how do you treat it? Well, lie down flat. And if you lie down, chances are everything is going to come back to normal. Now, sometimes if you have those prodromal symptoms, you can actually tense the muscles. You can squeeze your hand together. You can cross your legs. You can tense your arm muscles. You can bend over as if you're tying your shoe. You put your head between your knees. You can elevate your legs. And if you do that, chances are you're going to be back to normal within about the 12 seconds. Now, if the situation happens to be recurrent and it happens too often, then we consider, well, maybe you increase the fluid intake, increase your salt intake. Rarely we have to use medicines, and consideration of pacemaker. Well, because your heart rate is slow? No, pacemakers aren't really the problem, because the overwhelming majority of people, it's vasodilation. The blood vessels are dilated, and that's why you faint. Now, another kind of cause is the orthostatic syncope, the orthostatic hypotension. And this occurs when you stand up and your blood pressure falls by more than 20 millimeters on the systolic, the upper side. That's 120, now falls to less than 100. And the bottom number, the diastolic, falls by more than 10 millimeters. Now, in most of these individuals, there is not a compensatory increase in the heart rate. So the heart rate, remember, when your blood pressure goes down, your heart rate should speed up. But in people who have orthostatic condition, it doesn't. Now, in most people, this occurs about 3 minutes after they stand up. Some people get some lightheadedness about 10, 15, 20 seconds after they stand up. They have an initial fall in the blood pressure, and there's a temporary mismatch, but that rapidly gets back to normal. That's not orthostatic hypotension. Orthostatic hypotension is associated with the same kind of symptoms, the prodrome that we talked about a moment ago. You have the premonitory symptoms. You can have the generalized weakness and the fatigue and the slowing of the mind. Well, some people additionally, because of a lack of circulation, it can develop some problems with the vision temporarily, because the area in the brain that controls the vision, not getting enough oxygenated blood. Sometimes there's pain in the back of the neck, maybe the shoulder area, because the muscles aren't getting sufficient amount of oxygenated blood. We call it a coat hanger headache. Muscular ischemia. Sometimes people get short of breath because there's a mismatch between the ventilation and the perfusion. You're still getting air to the upper part of the lung, but you're not getting the blood flow to the upper part of the lung, so you get shorter breath. Some people even develop angina. Symptoms tend to occur more with exertion or prolonged standing, or if it's too hot, or very frequently after meals. Same sort of situation occurs. Lie down, seem to get better. The cause, well, It's failure of the autonomic nervous system, typically centrally or sometimes in the peripheral nervous system. And sometimes people who have abnormalities of the autonomic nervous system also have some bladder and some bowel problems, some problems with their sexual organs, and some sweating abnormalities. Well, it's very common to be associated with Parkinson's disease and a variety of other situations, and sometimes with diabetes or amyloidosis or B12 deficiency or HIV or certain kind of drugs, or due to just a decrease in the volume. More common in elderly individuals than younger individuals, more common after a big meal or after a lot of carbohydrate intake or after alcohol. And there are certain medicines seem to be associated with treating high blood pressure, or the antidepressants, the old tricyclic antidepressants, or the phenothiazines, the antipsychotics. People who are volume depleted because they've been perspiring, maybe because they've hemorrhaged, lost blood. Well, treatment is the same, but sometimes those people need some medicines, and the medicines haven't really been well studied, but for some individuals they're appropriate. The overwhelming majority of people know. Now, the other kind of syncope is the cardiac syncope. Now, unlike the neurally mediated syncope, when you have cardiac mediated syncope, that might increase the risk of sudden cardiac death. So you have to work these individuals up to find out what the cause is. Is it a bradyarrhythmia, slowing of the heart? Is it slowing of the heart because you have sinus arrest or you have an AV block, or is it because you're taking certain kind of medicine, or is it because you're suffering ventricular tachycardia? Or is it because you have some sort of genetic abnormality in some of the ion channels, a long QT interval, or a variety of other conditions? Or is it because you have maybe congestive heart failure, or an effusion in the sac around the heart? Or maybe it's because you have a hypertrophic cardiomyopathy. You have excess thickness of the muscles in the heart, or maybe because you have a valvular disease, or maybe because you have heart failure and the doctor's giving you too much in the way of diuretic or vasodilator, medicines that make the blood vessels open up. Well, for people who have cardiac syncope, the treatment is treat the underlying disease. Differential diagnosis of the condition. Well, we have to differentiate syncope from falls or from seizures or from ischemia of the brain from other causes or hypoglycemia. Falls are an interesting issue. You can have a fall with some head trauma, and then you can have post-concussive syndrome. You can have some amnesia for the event. You have loss of consciousness. And some people, it's difficult to differentiate. Did the person fall because of a syncopal attack? Did the person fall because of a gait abnormality or because of a vestibular abnormality? You lost your balance, you got a little dizzy. Those can be very difficult. The evaluation of people who have syncopal attacks, well, for the overwhelming majority of people, there's not much testing that needs to be done. Take your blood pressure, check the blood pressure, check the heart rate when you're sitting down, when you're lying down, then when you're standing up. And only in the people who are at risk, then we do some other kind of testing, electrocardiograms, or we can do some stress testing or some Holter monitoring or some echocardiogram. But for the overwhelming majority of people, especially young individuals, we don't have to do anything. And fortunately, the young people don't even go to the doctor's office because they realize what the problem was. So that's the story of fainting, syncopal attacks. Typically, there's no issue, especially in younger individuals. Easily explained situation in young people. Older people gets a little more difficult because we have the risk of age and we have the risk of other medical issues and we have the problems with medicines that people are taking. So if you're a little bit older, then a checkup is probably warranted. But fortunately, for the overwhelming majority of people with syncope, No in-depth medical evaluations are necessary. You don't have to go to the neurologist. You don't have to go to the cardiologist. The family doctor is more than adequate to make the diagnosis and tell you what to do, hopefully, to prevent excessive number of attacks. Anyway, thanks for watching. If you enjoyed the show, please tell a friend. Consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.